Very much.
Dr. Agnes, we can't hear you.
Oh, sorry about that. I realized I got a mishap when I was speaking. So hello, everyone. We welcome you to today's session. So today we are going to be talking about judicious use of NSAIDs in pain management. And with us, we have Dr. Esther Nafula, who is a palliative care physician and head of palliative care unit in Kenyatta National Hospital. And we also have Dr. Joyce Bombegi, a nephrologist at Mbagathi Hospital. They'll be introducing themselves further before they give their presentation. And we welcome you all to take part in this session. Please feel free to give your comments and your questions at the Q&A section, and we'll be able to go through them after the presentation. Welcome all. Over to you, Dr. Nafula.
Good afternoon, everyone. I'll start sharing my screen. So this afternoon, we want to talk about NSAIDs. I hope you're able to see my screen. So working in palliative care, 80% of patients are referred to us because of pain. And NSAIDs are among the common drugs that are used by patients. Patients know these NSAIDs by name. They're readily available over the counter. Some of them are recommended by prescription, others by their relatives or friends, and they're the commonest used analgesics. So some NSAIDs that come to mind when we're talking about common NSAIDs include diclofenac, brufen, ketoprofen, indomethacin, celecoxib, mefenamic acid. And a lot of patients self-prescribe these medications for themselves. So this afternoon, we want to discuss more about NSAIDs to just understand how they work, their indications, and some considerations, especially with patients with the issues with their kidneys, chronic kidney disease. Most patients on NSAIDs, some of them are cancer patients with advanced malignancies and kidney failure. So we want to know how to use these NSAIDs wisely. So when we want to choose analgesics for our patients, there are many factors that influence how we choose analgesia. The first one is the severity of the pain. The World Health Organization has given us guidelines using the 3-step ladder of which medication to choose for mild, moderate, or severe pain, and NSAIDs fall in all these categories. The source of pain, whether it is nociceptive or neuropathic, determines which painkillers we are going to prescribe. The duration of the pain, whether it is acute or chronic. Then the patient's age. Patients who are 65 and above are considered to be elderly with reduced hepatic and renal function. Therefore, sometimes we need to either choose medication that is safe for them or to adjust the doses of medicines. Again, some of these patients have comorbidities, especially elderly ones might be having hypertension, diabetes, and other comorbidities. So we consider that when we are choosing the appropriate analgesic for the pain. So NSAIDs are considered to be non-narcotic or non-opioid analgesics. So when we look at classifications of analgesia, we have the non-steroidal anti-inflammatory drugs, and then we have the opioid analgesics. So the NSAIDs act on peripheral pain mechanisms, but sometimes they also act in the central nervous system. So there are a group of drugs that have 3 major effects: analgesia, anti-inflammatory, and antipyretic. So they are used commonly for headaches, dysmenorrhea, toothaches, myalgias, fevers, arthritis, or bone pain. So the commonest indication, I think, among our patients, especially elderly patients, is bone pain and arthritis. For cancer patients, some of them present with bony metastases, and NSAIDs are the choice of drug for managing bone pain. So loosely, we can classify NSAIDs as selective and non-selective COX inhibitors. So the non-selective ones are the conventional NSAIDs. Then we have preferential COX-2 inhibitors, which is an example is meloxicam, and selective COX-2 inhibitors like celecoxib and etoricoxib. When we look at further classifying these NSAIDs, they can now be broken down into their classes depending on how they work. We start with salicylates, where we have aspirin and methyl salicylate. Then we have paraminophenol derivatives like paracetamol. We have indole and indene acetic acids like indomethacin. We have oxycam derivatives like meloxicam, phenylacetic derivatives like diclofenac, and then phenamates like mefenamic acid. So I chose just the commonest ones to understand that the classification of NSAIDs does not have to be very simple, but it's also complex when we start going into the specific classes of NSAIDs, and there's a variety of medications in this class of analgesia. So we'll go into the mechanism of action. So we mentioned three major functions of antipyresis, anti-inflammation, and analgesia. So the thermoregulatory center is found in the hypothalamus, and NSAIDs work to reduce fever by causing dilatation of superficial blood vessels, increased sweating or respiration, and promoting heat loss. So how pyresis comes about during infections or inflammatory reactions, the bacteria produces endotoxins, which release interleukin-1 from the macrophages that now stimulates the generation of prostaglandins. So these prostaglandins in the hypothalamus are what results in pyrexia or fever. So NSAIDs will exert an antipyretic effect by inhibiting the cyclooxygenase 1 or 2 or both of them, which are the ones that catalyze the reaction of prostaglandin formation from arachidonic acid in the hypothalamus, or through inhibition of the specific COX enzymes in the central nervous system. So COX-1 is the enzyme that is responsible for physiological synthesis of prostaglandins for tissue hemostasis, and COX-2 is responsible for synthesis of prostaglandins that have a role in fever, pain, and inflammation. So remember, we said some of these NSAIDs are specific COX inhibitors and some are non-specific, so they inhibit both COX-1 and COX-2. For anti-inflammation and analgesia, so inflammatory reactions, which include vasodilation and increased vascular permeability, and result in pain, again, are mediated by many chemical mediators, but the biggest function of NSAIDs is the synthesis of prostaglandins. So they inhibit synthesis of prostaglandins by irreversibly inhibiting the cyclooxygenase hormones. Therefore, the nociceptors to pain, when these prostaglandins are inhibited, then the pain reaction is reduced. Now, NSAIDs also have an antithrombic mechanism of action. Aspirin, for example, is highly active in the circulation, especially before the hepatic metabolism, and even in small doses, they produce antithrombotic effects. That's why we use aspirin for myocardial infarction and other cardiac conditions. Now, for neonates, NSAIDs are used to treat a patent ductus arteriosus, which is a shunt that connects the pulmonary artery to the aortic arc. And this shunt is maintained by local prostaglandins. So when we prescribe opioids in the third trimester, they cause premature closure of that ductus arteriosus. That is what makes them to be contraindicated in pregnancy, especially in the third trimester. And for children who are born with a patent ductus arteriosus, they are given low doses of aspirin or indomethacin to create closure of this ductus arteriosus. So some side effects include in the gastrointestinal system, NSAIDs will cause upset or acidity, hyperacidity. They can cause bleeding and nausea, and it is because of the mechanism of action, and this is reduced by us prescribing NSAIDs together with a proton pump inhibitor or a H2 receptor antagonist. They cause a lot of renal toxicity. They also can result in bleeding disorders, allergies, hypertension, and hepatotoxicity. So some drug interactions that we need to be aware of when we prescribe NSAIDs together with ACE inhibitors, it leads to increased hyperkalemia. When we prescribe together with steroids or warfarin, there's increased risk of GI ulceration and bleeding. So they have to be used cautiously, or we need to lean more towards the selective COX inhibitors more than the non-specific NSAIDs. So I would like now to hand over the session to Dr. Joyce Bobwengi, who will take us through more of the mechanism of action of NSAIDs, especially considerations for renal patients, including what options we have when we do need to prescribe an opioid. An NSAID. Thank you.
Thank you very much, Dr. Nafula. Thank you everyone who's attending. Kindly allow me to share my screen. Thank you for the very lovely introduction that will allow me to present my presentation, give my presentation today. Is my screen clear?
Yes, Doc, it is. You can go ahead, yes.
Okay, my name is Joyce Bombengi. I'm a consultant physician and kidney specialist, currently working at Mbagathi County Referral Hospital. And thank you for this opportunity to discuss a little bit about NSAIDs and their use in palliative care and its effects on the kidney. So it's a very important discussion because initially when I was doing this presentation and after having the discussion with Daktari, had really highlighted mostly management of pain in patients with cancer or who are on palliation. And we know that it's a prevalent symptom experienced by patients who are either on treatment for cancer or on palliation, affecting about 30 to 70% of these patients. We know that appropriate use of simple therapies can effectively relieve pain in majority of the patients. In 1986, the World Health Organization gave us the analgesic ladder, which is not really an evidence-based guideline, but it's a framework for stepwise and systemic approach of management of pain. And this has already been highlighted by my colleague. So I'll quickly go through it, but this is a picture. You can see we have step 1, 2, and 3. And at the bottom there, you have the patients with mild pain, whom you give non-opioids. These non-opioids include the NSAIDs and the acetaminophen. So we know that NSAIDs are one of the most common classes of medications used worldwide, or with an estimated usage of about more than 30 million per day. This includes prescriptions and over-the-counter purchases. And 1 to 5% of these patients experience adverse renal events. This translates to about 2.5 million patients per day. The good thing is that the risk reduces once you stop taking the medication. It's important for me to document that kidney disease secondary to NSAIDs can occur with any class of NSAIDs, whether it's selective, non-selective, and there are various factors that we will look at, which will help us understand why this happens. I know that it's very important that most people say, okay, if I can't give an oral NSAID, can I give a topical one? Topical NSAIDs can also induce the systemic side effects that we are going to see. So Daktari had already classified the NSAIDs. So this was just a picture showing the same, the chemical structures. I will pass over it, but of note at the bottom here, I want you to see COX-2 inhibitors, celecoxib and etoricoxib, which were initially developed to get rid of the side effects that we commonly see when taking NSAIDs. And we want to discuss a little more. Are they really, really safe? Is there, is there a safe NSAID to use? So going further on, she had also described this. Of all these medications, they're all reversible, like the mechanism of action. However, aspirin is the only one that has that works irreversibly. It irreversibly blocks COX-1 and COX-2. So this is still another explanation. It's important for us to know why these NSAIDs are so different and how they have different effects on the body. When you look at COX-2 selectivity on this bar graph on my, this bar graph here, you can see that ASA is more aspirin is more COX-1, and then we have etoricoxib and celecoxib down here being more COX-2 selective. The other thing that determines how the NSAIDs work on the body is according to the time that they work in the body. So we have short-acting NSAIDs like ibuprofen and ketoprofen. And then we have those long-acting ones like celecoxib and naproxen. We do not have Salinda in the market anymore. Having said that, Dr. had highlighted the two forms of cyclooxygenase enzymes. The cyclooxygenase 1, she had already mentioned, is a constitutive form that is active in tissues that require prostaglandins for physiological function, like the stomach lining, the intestines, the kidneys, and even when for the platelet function. And we have the inducible form, which is a cyclooxygenase 2, which works to produce inflammation, resulting in pain and fever. So it's a delicate balance. When you want to prescribe the NSAIDs, you have to look at the beneficial health effects versus the detrimental ones. Of course, Dr. had mentioned the 6 A's, or the 5 A's rather, the anti-inflammatory action, antipyrexis, analgesia, and the antithrombotic actions, which are what is important for us as physicians. And then the detrimental side effects, on the other hand, which are the gastrointestinal complications, hepatotoxic problems, kidney injury, cardiovascular problems, cerebral complications, and respiratory tract issues. So every time you have a patient, these are the things that you need to consider before prescribing, and they will also help you to know, do you want to use a long-acting, short-acting, for how long are you going to prescribe the medication? So onto the major physiological roles for cyclooxygenase 1 and 2, and the mechanisms underlying the drug-induced side effects. She had already talked about arachidonic acid and how the cyclooxygenase comes to produce the prostaglandins. At the level of the GI mucosa, cyclooxygenase 1 helps us to produce PGE2 for gastric protection by increasing mucus secretion, increasing bicarbonate, and increasing mucosal flow. So when you give NSAIDs that block cyclooxygenase 1, COX-1, let me just use COX-1 and COX-2. When you give NSAIDs that block COX-1, you end up having peptic ulcers and GI bleeding. At the level of the kidney, which is the area we're focusing today, for NSAIDs that block COX-1 and COX-2, normally, okay, so COX-1 and COX-2 help us to produce PGE1 and PGI2, which is important for afferent arteriolar vasodilation. Therefore, you have increased GFR, and then they help us to excrete sodium and water excretion. So for a normal patient who has normal hemodynamics, the prostaglandins don't have really a big role, but they come in, especially like if you have reduced effective circulatory volume, like if you get dehydrated, you've had massive blood loss, and so on and so forth. So they work by increasing water. Yeah, so they work by increasing the flow of blood through the glomerulus, hence a higher GFR. So when you give NSAIDs that block the COX-1 and 2 at the level of the kidney, you start having sodium and water retention. And then you get hypertension and hemodynamic acute kidney injury. There's something else I'm going to discuss as well, a different type of acute kidney injury that occurs when you use cyclooxygenase 2. So I'm not going to go into the cardiovascular side effects as I'm sticking to our topic. So I have said that the side effects of NSAIDs affect various parts of the body. The kidneys, the GI, the cardiovascular system, they cause bronchospasms, liver toxicities, and they have an antiplatelet effect. Remember, for patients whom we use medication like aspirin for the antiplatelet effect, it's usually for the beneficial effects of that antiplatelet effect to prevent cardiovascular disease or cardiovascular complications, but it's actually a side effect of the NSAID. So why do we all respond to NSAIDs differently? So the different NSAIDs have different half-lives. Some of them have drugs that they have components that they have components of their drug that are produced after metabolism. That's the enantiomeric conversion. different levels of urinary excretion, pharmacodynamic variation, different protein binding. We know that NSAIDs work by, they're highly protein bound, the different metabolic profiles of the drugs. And we have genetic variability in the cytochrome P450. For example, patients are frequently slow metabolizers through the CYP2C9 pathway. Therefore, they might benefit from a lower dose or a less frequency of the NSAIDs. And then the pharmacokinetics of some NSAIDs are affected by hepatic disease, renal disease, and old age. So since the kidney is our area of interest, there are three main ways you can get kidney disease. There are very many syndromes that are associated with NSAID use, such as acute kidney injury, acute and chronic interstitial nephritis, nephrotic syndrome, hyponatremia, hyperkalemia, elevated blood pressures, acute papillary necrosis, and even uroepithelial malignancies. But these are the main things that I want to talk about. So for patients who get acute kidney injuries, these patients have disorders of either the heart, the kidney, or the liver. So for example, patients who have heart failure, those ones who have nephrotic syndrome, or those who have liver failure, they have reduced effective circulatory volume. That's the volume of blood that is passing through the kidneys. So when you introduce the NSAIDs, you cause hemodynamic disturbances, hence your acute kidney injury. Now, for those who are on prolonged exposure to NSAIDs, some of them get hypersensitivity reactions, and I'm going to explain how that comes about, resulting in this interstitial nephritis. Then also those who take NSAIDs for a long period of time, they will have hemodynamic disturbances that are not reversed or reversed in good time. Remember, I told you that when you take NSAIDs, most of the actions are reversible, especially if you've taken for a short time. But if you take them over a long period of time, you have those continuous hemodynamic disturbances resulting in chronic kidney disease. So this is a pictorial presentation of what normally happens with the prostaglandins in the kidneys and what happens when you take NSAIDs. So when you produce PGE1 and PGE2 and PGI2, I had told you earlier that you'll have reduced sodium reabsorption. This is at the level of the proximal tubule, at the loop of Henle, and the distal nephron. So what happens when you give NSAIDs, you end up with sodium retention. So your patient will have peripheral edema, worsening of hypertension, and a worsening of heart failure. And this is very common. We find patients who are on antihypertensives and they have back pain, they have pain here and there, and you're wondering why they're not responding to the medications well. Go back and look at their medication. Sometimes they're taking NSAIDs, which are preventing you from having good blood pressure control. And the second column here, we see that prostaglandins stimulate renin release. This causes an increased secretion of aldosterone, hence an increased excretion of potassium and acid, and reduction in water reabsorption at the distal nephron. When you give a patient NSAIDs, you get hyperkalemia, you will get type 4 renal tubular acidosis, and hyponatremia. When we look at the fourth column here, the prostaglandins cause vasodilation, especially at the afferent limb, resulting in increased renal blood flow, an increased GFR, and peritubular papillary blood flow. Now, when you give NSAIDs, your patients are at risk for prerenal AKI and ischemic injury. This is just a similar picture showing the same for those who will want the presentation. And just another pictorial presentation of where the different cyclooxygenase enzymes work. So the green ones, they're green locations. That's at the level of glomerular mesangial cells, and at the collecting duct is where you have the COX-1. And then the blue one, that's COX-2, is at the loop of Henle, the macula densa, and the glomerular podocytes. And then the black areas show where you have overlapping of both COX-1 and COX-2. Having said that, what are the adverse effects of NSAIDs on the kidney? So I had mentioned acute kidney injury, which can be both hemodynamic or because of acute tubular injury, hyperkalemia, hyponatremia, hypervolemia, and sodium avidity for those I had mentioned, exacerbation of blood pressure, acute interstitial nephritis, nephrotic syndrome, acute or chronic papillary necrosis, and progression of kidney disease. So you see, NSAIDs are not necessarily as innocent as people imagine. We should not just be popping them all over the place, out over the counter. You should really pay attention before you prescribe them or use them yourself. So I'll go to the most important side effect first, which is the NSAID-induced AKI. So I had said that the injury can either be hemodynamically mediated, that is when you have pre-renal injury or acute tubular necrosis, or immune-mediated resulting in acute interstitial nephritis. So for the hemodynamically mediated, it's dose and duration dependent. So the amount of NSAID that you're giving and for how long, usually it is reversible within a short time after you stop it. And there are 3 groups of patients who are at risk of developing AKI by this mechanism. That is your elderly patients above 65 years, those who have severely decompensated liver disease, and patients with congestive heart failure. Remember, these are the people who have reduced effective circulatory blood flow. Then you have those who have immune-mediated interstitial nephritis. It's an idiosyncratic reaction. It happens in about 50 to 20% of all the patients who have NSAID-induced AKI. It's typically a delayed hypersensitivity reaction that occurs after NSAID exposure of about a week. And it's more common when you give phenoprofen, naproxen, and brufen. And frequently they develop a full nephrotic syndrome, picture of nephrotic syndrome. This is just a picture showing the changes in the afferent arteriole, as I explained, resulting in pre-renal AKI. These patients will typically present with reduced urine output and they'll have edema, elevated urea and creatinine, hyperkalemia, high blood pressures, and fractional excretion of sodium of less than 1%. That's one of the ways you can know what type of NSAID injury you have. So these risk factors, I think it's important I repeat them because they're very important. Patients who already have CKD, patients who are volume depleted from aggressive diuresis, vomiting, or diarrhea. And right now, we have been giving a lot of SGLT2 inhibitors for diabetes, heart failure. It causes quite a bit of diuresis. So that's one of the medications I should have added to the list. I had mentioned patients who have reduced effective arterial blood volume, patients who have severe hypercalcemia, renal artery stenosis, and those medications listed there: diuretics, ACE inhibitors, ARBs, CNIs. So look at all your patients who are post-transplant or who are on follow-up with the rheumatologist, and higher doses of NSAIDs. Actually, the higher the dose, the more your patient is at risk for an AKI. So there's this important thing called a triple whammy effect. I know that many times you have a patient who's on a diuretic, or an ACE inhibitor or an ARB, then you add an NSAID. And these patients have an increased risk of AKI of 30%. It's called a triple whammy effect. So how do we prevent NSAID-induced AKI? Of course, Dr. had talked about the alternative analgesics like opioids. Let's use those. If not, and you must use them, use a low dose of NSAID for a short duration of time. Avoid ACE inhibitors, ARBs, and diuretics and NSAIDs in patients who have high risk or are dehydrated. Ensure you do appropriate monitoring, and I'll tell you how to do it. And then if your patient gets NSAID AKI, kindly discontinue the NSAID. I had also said that recovery is rapid and baseline function is usually restored. So this is just a picture showing some of the studies that have been done. This one was done by Fine-1 et al., where they compared the risks of different NSAID drugs on chronic kidney disease. And they concluded that the highest risk was observed in patients who were using etoricoxib compared to that with ibuprofen. When you go into the study in details, you can see like ibuprofen is a shorter acting, etoricoxib is longer acting. There are many factors, but there have been many studies to try and find out, whether there's a really, safer NSAID, but I hope that this is a discussion we'll get from the floor and from Dr. Nafula telling us, is there a safer NSAID? Had also alluded to this other condition, the NSAID-induced acute interstitial nephritis, which I had explained is an immunological reaction. So for other patients who get immunological reactions causing interstitial nephritis, they usually have this fever, rash, eosinophilia, but this is usually absent in patients who have NSAID-induced nephritis. For these patients, if they really have worsening creatinine, really worsened creatinine, and they acutely require dialysis, consider doing a biopsy for them. The other thing is that interstitial nephritis secondary to NSAIDs hardly responds to corticosteroids, and you want to avoid these drugs going forward because it's a hypersensitivity reaction and it's expected to recur with rechallenge. So for those patients who get this, discontinue the offending agent. If they require dialysis, ensure you do it and you do a kidney biopsy within 24 to 72 hours of the initial evaluation. So there was a study done for the chronic renal insufficiency cohort where they looked at the pattern of NSAID use and the association with chronic kidney disease. So the surprising thing is that there's a high rate of NSAID use in CKD. We need to do our own local studies. And this was a study done over about 5 years period on patients who had CKD aged 21 to 74 years. So they were more likely to get an NSAID used. However, if they saw a nephrologist, they were less likely to get an NSAID prescribed. And when they had progression of kidney disease, so those who had worsening of kidney disease and they saw a nephrologist were more likely to have it converted to an alternative drug. There's a lot of information that you can get from this paper, but maybe we need to look at our own patterns of prescribing NSAIDs and even just asking our patients, how many have used NSAIDs? When we're reviewing patients with kidney disease, how many take over-the-counter NSAIDs and how long have they taken? People really do not know this. And this is both in the medical field and amongst the patients themselves. So we need to really highlight this. So I'm almost approaching the end. I will also just highlight NSAID-associated hyperkalemia. And I had told you it works by blocking the renin-angiotensin system, resulting in reduced function of aldosterone. Therefore, you have retention of the potassium. And this is more common in patients who have a prior episode of hyperkalemia, patients who've had hospitalization within the last 1 month, those who have diabetes, or those who've had an AKI. For those patients, just avoid giving NSAID. So the risk factors are concurrent medications, as I had earlier alluded to. Those are your ACE and ARBs, trimethoprim, heparin, and then patients who have been exposed to radiocontrast with concomitant RAS inhibition, those who are above 65 years old, those who have hyporeninemic hypoaldosteronism, and those who have type 4 renal tubular acidosis. So I had also told you about NSAID hyponatremia, and this is because of the increased water retention. I'll not repeat that. Those who are at risk for this are those who have, so patients who have underlying conditions that promote water retention are at a higher risk for hyponatremia with NSAID exposure. So those who have true or effective circulating volume depletion, conditions associated with the syndrome of inappropriate ADH secretion, patients who have increased free water intake with or without increased sodium losses, especially those who have extreme exercise, and if you're co-prescribing a thiazide. I had also talked about hypervolemia, so I will not belabor this. And I had also explained about worsening hypertension, and their blood pressures typically rise by about 3 to 6 millimeters when you introduce the NSAIDs, and this is because of water retention and increased peripheral vascular resistance. So be careful in patients who have underlying hypertension, those who are elderly or have diabetes mellitus. So one very interesting thing that people forget is a cause of NSAID, can be caused by NSAID is nephrotic syndrome. And here is a study by Bakir Mohammed, who looked at the risk for nephrotic syndrome in patients who are using NSAIDs. And you can see they had about 10,454 controls. And what they found is that use of conventional NSAIDs was associated with a higher risk of nephrotic syndrome, starting from at least 2 weeks of exposure. The higher risk was also shown for recent and past exposure up to 2 years. So if you're starting your patient on NSAIDs, apart from checking the kidney function, the urea and the creatinine, do a urinalysis. And if you start seeing proteinuria, you will have an increased need to check for nephrotic syndrome. And there are 2 types that you can get. You can get either membranous nephropathy or minimal change disease. And they usually occur about weeks to months after the initial NSAID exposure. So a little bit of detail about minimal change disease secondary to NSAID. It's a complication of NSAIDs, of course. These patients typically present with severe acute kidney injury, accompanying nephrotic syndrome manifestations, your hypoalbuminemia, edema, and proteinuria. And when you do a kidney biopsy, you'll find a characteristic pattern of drug-induced acute interstitial nephritis. The glomeruli are usually normal on light microscopy, but you find a diffuse effacement of the podocyte processes on electron microscopy. Typically, it resolves after you discontinue the drugs. And for some patients, a short course of corticosteroids might help. For those who get membranous nephropathy, you will typically see it this in a patient who has nephrotic syndrome with normal kidney function. Remember, the one who had minimal change will have acute kidney injury. And these patients will have electron-dense subepithelial deposits along the glomerular loops and a complete effacement of the food processes on kidney biopsy. So this information is more important for those who are interested in the details of the nephrology behind it. So the patient who, as I come to draw to the end, I think it's also important to know that for patients who already have chronic kidney disease on NSAIDs, you are more likely to progress if you're more than 65 years of age. You have a high cumulative dose exposure, means that you're either getting a very high dose or a high frequency, or you've been taking it for a really long time. Those who have coronary artery disease, and those who are on a combination of analgesics. So this last picture shows you a very sad condition that can happen when you have NSAIDs, this papillary necrosis. So it's usually the end result of chronic medullary hypoxia. So you have reduced oxygenation of at the level of the medullary, and it starts sloughing off and shedding into the renal pelvis. The patients might be asymptomatic, or sometimes they present with severe flank pain. They might have visible passage of the papillae, in their urine, frank hematuria. And when you do your imaging, you can get unilateral features suggestive of a unilateral ureteric obstruction. It's typically common in your patients who have also diabetes, sickle cell, or those who are being managed, who initially had obstructive uropathy and have just been managed. So for these patients, you will do a contrast CT and you'll see irregular papillary tips and loss of the papillae. And if you do an IV urography, you'll see a ring shadow. So people forget that sometimes you prescribe NSAIDs for patients and they're not getting relief, and then they take more and more and more to get better. So NSAID overdose is common. Your patient will present with nausea, vomiting, drowsiness, an iron gap, acidosis, seizures, or even aplastic anemia. And if they have AKI, it's usually reversible. So the treatment for them is conservative. For these patients, hemodialysis is ineffective due to the high protein binding of the NSAIDs. And you can consider plasmapheresis in patients who have severe intoxication or have anaphylaxis. So for our recommendations, we should cautiously use NSAIDs, avoid using NSAIDs in patients who have life-threatening complications such as AKI, hyperkalemia, or hypervolemia. And for patients who are CKD stage 1 and 2 without predisposing factors, give the NSAIDs, give them for a short time, try to eliminate the pain as soon as possible, and monitor the patients. Do your urea and creatinine, check your urinalysis, and you'll do this within 2 to 3 weeks of starting your NSAID. For those who have CKD3 with predisposing risk factors, minimize the amount you can give. If you have to give for severe pain management, give it short term and convert to something more appropriate. Short-acting agents are preferred over long-acting agents. Always optimize your patient's volume status and cardiac function, and adjust the NSAID dosing according to how the patient responds, and according to their kidney function, especially for those who have reduced elimination. Avoid NSAIDs for those who have heart failure, nephrotic syndrome, liver cirrhosis, and so on and so forth. Always look at the other drugs that you're giving your patients. Make sure you're not putting them at risk. So for patients who have renal disease, always start those with mild pain with your paracetamol and an adjuvant. I'll tell you what these adjuvants are. Then move up to hydroxycodone and an adjuvant. And for those with severe pain, use a non-opioid, an adjuvant, and moderate to strong opioids. For example, fentanyl. Remember, even when you're giving this strong opioids, your patient is not able to metabolize it as well as a patient who is stable. So they'll start getting the drowsiness and all the other side effects, and you might have to give naloxone. So give a low dose, reduced frequency. Here's a table, some tables showing some of the adjuvant analgesics that can be used for cancer pain, especially for your patients with CKD. Glucocorticoids, we've seen dexamethasone commonly being used to help with the pain. Antidepressants, we've used SNRIs like duloxetine. You can use topical analgesics like capsaicin, lidocaine, anti-seizure medication like gabapentin and pregabalin, which we commonly use. And those are others that have been used. For those with bone pain, you can use biphosphonates like palmidronate, depending on the patient's kidney function. And for bowel obstruction, you can use anticholinergic drugs and somatostatin analogs. So finally, NSAIDs cannot be safely used in people with chronic kidney disease because they're always risky. So this does not mean that we completely cannot use them. And you have to look at your patient, look at their side effects. Not their side effects. Look at your patient, look at their comorbidities. What other medications are they on, and possible problems that can come up, and then you make the decision to prescribe. Thank you very much. Dr. Nafula.
Thank you.
Yes, thank you, Dr. Joyce, for the wonderful presentation. I think we'll hand over to Dr. Karingo for the Q&A session.
Yes, indeed. Thank you very much, Dr. Mubegi. That was very precise. And also Dr. Nafula. For those who joined us when the presentation had started, today we are talking about judicious use of NSAIDs, and with a special focus on the renal patient. And we've just had two presentations going over the overview of NSAIDs, and this just finished presentation going over the NSAID use in the renal patient, and we really appreciate the concise presentations. So we do have a couple of questions. Maybe I'll just go through them from the chat. From the Q&A section. Elma, there's Mercy Minor who is asking Elma effectiveness during lumbar puncture procedures in neonates. Dr. Rafla, if you'd like to take that.
Now, that is a topical analgesic that has anesthetic, local anesthetic. I think it is useful in giving anesthesia, but just at the skin level. The lumbar puncture might still be painful. So maybe we just need to review about the use of local anesthesia when doing a lumbar puncture, because you might need maybe the injectable ones that can be able to give anesthesia beyond the skin.
There's someone here asking about some information about paracetamol.
Yes, it's not an NSAID.
Yeah, it's paracetamol, not an NSAID.
I could comment on that as well. So it's an aminophenol derivative. It has antipyretic and analgesic effects, but it's just in a class of its own.
Thank you for those responses. Maybe next one we can put for us up the poster as we continue with the questions. So we have a question here. So Dr. Rafla, kindly elaborate on the duration of therapy using NSAIDs without PP H2 blocker, PPI H2 blocker. Also comment on the use of combination therapy, that is using NSAIDs and opioids, from Wycliffe.
Okay, now randomized controlled trials that have been done for use of non-selective and selective NSAIDs have shown that the risk of getting gastric ulceration, which has been defined as evidence of gastric ulcers on endoscopy, was found to be the same. So many guidelines have actually recommended that when you're using NSAIDs, be they selective or non-selective COX inhibitors, you need to prescribe a PPI. The reason for that is just to prevent. It is a sort of prophylaxis for the gastric ulceration. So just based on what research has shown, I would not recommend just giving NSAIDs, especially if they're going to be used for a long time. They should not be given without a PPI. When it comes to using combinations, the World Health Organization ladder, the 3-step pain control ladder, has advised that we can combine opioids and NSAIDs. And the reason for that is because they work on they have different mechanisms of action. NSAIDs will inhibit production of prostaglandins, and opioids work on opioid receptors. So the combination is actually advised, especially at all steps of the ladder. When patients have severe pain or moderate pain, we might want to combine the medication because they work on different pathways so that we are able to achieve pain control. So the important thing when we want to combine opioids and non-opioids is to try and ask yourself, what is the pathophysiology of the pain that the patient has presented with? What is likely causing the pain? Is there an element of inflammation? Yes or no? Is it nociceptive or neuropathic pain? Because if it is purely nociceptive, sometimes NSAIDs alone or opioids alone can control that pain. If it is a mixed type of pain or there's some neuropathic element, then one medication alone will not be able to control. Therefore, there is room for you to combine the analgesic classes.
Thank you for that elaborative response. Maybe Dr. Mbengi, you can comment on this next one on diclofenac on the menstrual flow. So there are some concerns about diclofenac and stopping the menstrual flow. Any comments on that?
I'm not very sure, but I know that it works. The menstrual flow is affected by prostaglandins. So I believe that when you give, for patients who, I know that we use it for dysmenorrhea for patients who have really bad menstrual cramps because of the elevated levels of prostaglandin. But maybe Dr. Nafula can comment. I really moved on from obstetrics thoroughly, so but I know that it would affect the prostaglandins. I don't know.
Well, I'm also not very sure about the exact mechanism, but the inhibition of prostaglandins is thought to have an effect in reducing the menstrual flow. I know for menorrhagia, mefenamic acid is a go-to medication. The exact mechanism of action, I'm not too sure, but also for menorrhagia, hormonal treatment is better at stopping the menses than NSAIDs, and sometimes they're used in combination.
Thank you. So some comments here about great presentation. I think I've seen more comments on that. Thank you very much, Mary. For the slides, you'll be able to share them once we get them. You can share them at knhresearch@gmail.com, and we can be able to see how best to share them. We'll also upload them in our website once we have that chance. For the next question, asking about the essential list, the WHO essential list, medication list. Why was diclofenac removed? And I think there's a similar question later on of someone who is asking also about sharing that WHO essential list again. Maybe Dr. Mbengi, you'll take that.
Okay, I can share the list, the essential list. So I didn't understand the question. You want me to explain why diclofenac was removed? I don't know.
Oh, this, yeah, he's asking why was diclofenac removed from the WHO list on the WHO in the list of essential medicines, whereas other NSAIDs also have similar side effects, or even worse, for example, aspirin is known to cause very bad GI irritation. And a second question on somebody who was just asking you to also to just do an overview again of the WHO essential list, just a brief.
All right, I can do an overview. So I don't know why, or if at all, diclofenac was removed from the essential list because it's in some hospitals. But the WHO analgesic ladder, basically it's in three levels. At the first level, you have, let me see if I can share it with you. You have the use of, okay, screen sharing was stopped.
Let me share with you the ladder doc, then you can.
Yeah. So at the bottom there, you have the use of non-opioids. So you have paracetamol and, oh, there it is.
Sure.
You have paracetamol and adjuvants. And so paracetamol, NSAIDs, and adjuvants. I'd given you a list of all those adjuvants: pregabalin, duloxetine, amongst others. There are very many. Then for the second level, we have opioids for mild to moderate pain. So we have the non-opioids, which is whatever is in level 1, and adjuvants. And then level 3 has the more potent opioids like fentanyl. I believe that's the question.
Yes.
Okay.
Yes. That's
that ladder. Yes.
The second
yes,
one.
that has.
Yeah, the second level has hydrocodone and oxycodone. I think they're less potent opioids. I don't know if that's, yeah.
Thanks for that. We'll continue with the questions. Is it true that topical NSAIDs have similar side effects as the oral dosage form?
Yes, I mentioned that in the presentation.
Yes. What alternate analgesic do you use for your patients with renal failure?
So I had mentioned that we use opioids. For those who do not have other contraindications to paracetamol, we can start with paracetamol, then we use the adjuvant analgesics, and then you go up the ladder with the opioids, the moderate ones and the more potent ones.
Yeah, thank you for that. Yes, so some of these things had been answered in the presentation, but we'll just quickly answer them in case we did not get them. Please explain how severe hypercalcemia is a risk factor for NSAID-induced AKI.
Okay, so hypercalcemia will cause a reduction in your GFR, and you have increased sodium excretion and a total depletion of your total body water, resulting in problems like metabolic alkalosis. So yeah, sorry, but mostly they reduce GFR. Sorry, I'm choking.
Sorry for that. Thanks. The next question is, can the opioids be used as a substitute or alternatives for NSAIDs? I think that has been answered. Which opioids, since opioids are POM rather than OTC medications?
I didn't get the question.
Can the opioids be used as substitute or alternatives for NSAIDs?
Yes.
That's definitely yes. And which opioids, since opioids are POM rather than OTC medications?
So we had mentioned the different level of opioids. So of course, by the time you assess your patient, there are alternative ways of managing the pain that we had mentioned. But if your patient has really mild pain, you'll start with your paracetamol and your adjuvant medication, then go up accordingly, according to the ladder that we had discussed. I think maybe, I don't know if Dr. Nafula has something to add on to that.
Yeah, so for patients with CKD, in our setup, morphine is the most available opioid, readily accessible. So we do calculate the dose based on the estimated glomerular filtration rate. So for renal patients, you need to adjust the dose from 50% or up to even 75% of the normal starting dose. But the best opioid for renal patients is actually a fentanyl patch, because it does not affect the kidney function, although sometimes now there's issues of efficacy when it comes to now overall pain management. So it is good to look at the patient as a whole and consider the alternatives of the treatment, and of course work with the nephrologist to decide which medications to choose, because some pain, like bone pain, will not be sorted out completely by opioids, and you might still need to use the short-acting NSAIDs.
Yes, may I also add that there's a drug called Nefopam. It's a non-opioid painkiller that you can use for moderate to severe pain, and it's safe, more or less safe for the kidney. And for patients with liver disease, you titrate accordingly. So we have some options.
Thank you for those responses. On the next question, from Masin Jogo, thank you for the wonderful presentation. Is it safe to give NSAIDs in sickle cell anemia, and also say something about NSAIDs in asthmatic patients? So this is beyond what we were speaking, but maybe we can have a comment on NSAID use in sickle cell anemia and in asthmatic patients. Dr. Nafula, would you like to?
Yeah, I could comment about the asthmatic patients, and then Dr. Joyce can comment about the sicklers. So NSAIDs are thought to trigger exacerbation of asthma, especially aspirin is notorious for that. But sometimes now it's to look at risk versus benefit, because some asthmatic patients might actually need those NSAIDs. Like if an asthmatic patient presents with a myocardial infarction, aspirin is one of our mainstays of treatment. You might still want to give the NSAID and manage the asthma. And the reason for that is just the issue of the prostaglandin synthesis and the issue of how asthma allergic reactions take place. So NSAIDs, sometimes they will trigger an asthmatic attack, but still we use them cautiously. It's not that we totally do not use them in asthmatic patients, but we look at risk versus benefit.
I would say the same for sickle cell patients. We use NSAIDs, but you have to be very cautious as you use them. Is your patient well hydrated? Do they have any other contraindications for the NSAID use? Because when you have sickle cell, you also have sickle cell nephropathy. So if your patient already has baseline reduced kidney function, you would not do that. Then your patients with sickle cell, sometimes, most of the times, by the time they're presenting with a crisis, they have reduced, they're hypovolemic, they're dehydrated. It's not safe to use NSAIDs. So we had highlighted this in the discussion. It's something that you'd probably want to avoid. So you'd opt for the other pain medications. But if you have inflammation and your patient is in a lot of pain, what do? I think I'd use it. We have some pain specialists in the audience. Maybe they can comment. I see Dr. Munyuri is there.
And just try to unmute him, then he can comment. In the meantime, we can continue with some of the other questions. We still have a few minutes to do the Q&A. So the next one, what is the effect of paracetamol on the kidney compared to NSAIDs? There are many studies out there which say it has significant risk and is nephrotoxic. That's a question from Kodiwa.
All of them are nephrotoxic. I think it's all, you have to, yeah, but the NSAIDs are worse.
Then there's this comment on the diclofenac that keeps coming up, whether it was removed from the market or not. I think we've mentioned something about that already. Then there's a question from Benjamin Otheno. Kindly, if you can elaborate on closure of adductus arteriosus. I think Dr. Nafula, you had mentioned in your presentation.
Yes. I mentioned that when we give NSAIDs in pregnancy, especially, yes, when we give NSAIDs in pregnancy, especially in the 3rd trimester, they do cause premature closure of the ductus arteriosus. That ductus arteriosus is maintained it's patent because of production of prostaglandins. So when we inhibit those prostaglandins, then it closes. So NSAIDs are generally not safe in pregnancy. I actually saw a question about analgesia in pregnancy. The only analgesic that has been studied among pregnant women is paracetamol. It's the only one that is category A, where it means it is safe for use in pregnancy. Other analgesics have to be used with caution. Again, we look at risk versus benefit, and we look at the underlying causes of the pain and the effects on the fetus, and even what effects might happen after delivery. So of course, the biggest hindrance to research in pregnancy is that ethical committees do not approve research in pregnancy because you are posing risks to 2 lives. So a lot of research has not been done around analgesia in pregnancy.
Thanks. I think that, yeah, and I've actually answered also a question that was asked on the use of NSAIDs in pregnancy. Let me see, on our next question, I think majority of these now have been mentioned in either some of the answers or in the presentations themselves. So we'll give it maybe another few question and answer, and then we'll call it, we'll come to a close with a small presentation from Menarini, who have sponsored this today's session. So from Deborah, can you comment on use of tramadol or tempatadol? So comment on use of tramadol or
tramadol is a weak opioid. Tramadol is categorized as a weak opioid and methadone as a strong opioid. So tramadol is effective for moderate pain and methadone for severe pain. So again, when we are choosing opioids, one of the things we look at is the side effect profiles, the availability. Tramadol will cause a lot of nausea and vomiting. We have to give with an antiemetic. Methadone causes a lot of cardiac side effects, so we need baseline cardiac function and monitoring. In our setup, we are not using it much as an analgesic, but in other setups, research has shown that it's actually a good alternative to morphine and pethidine, which are highly abused, because it is an addictive type of strong opioid. Maybe in future we'll adapt using methadone, but for now we use it a lot for rehabilitation.
Thank you for that. I'm actually saying we'll need another, we do have also another session on pain management in the coming week. And I think some of this we'll be able to also to mention in that session. I've seen one in relation to nephrology. Let me just get it. Our NSAIDs from Frank Longa, are NSAIDs contraindicated in post-pain? Dr. Bombegi.
Sorry, you're breaking a bit. Are NSAIDs contraindicated in what?
In post-nephrectomy or post-renal transplant patients with moderate severe pain.
I typically wouldn't use an NSAID unless I have no other. No, I wouldn't, because if you have a patient with just one kidney remaining, you want to ensure that they have good blood flow through it. So I would use alternative painkillers, not an NSAID.
Thank you. Then there is use of, is there any risk in using both tranexamic acid and ibuprofen in management of painful menses, from Titus Chalo? I think there was another question on the combined ibuprofen. We just mention a bit on the combination medications and when we can use them.
Dr. Nafula had highlighted it, and I think it's all on a case-to-case basis. Dr. can comment, but we have, yeah, it's on a case-to-case basis.
Yeah, I think, okay, there are a lot of questions around management of gynecologic pain. I am not an expert in gynecology, so I'm not sure whether we can combine the NSAIDs for menstrual pain but I think we could challenge the gynecologist to give us a session on managing pain. Then combination medications, most of the combination medicines, the baseline combination usually has a weak opioid and an NSAID, or you find paracetamol and a weak opioid. So again, it is just to try and minimize side effects of the medications while giving the patient the advantage of the multimodal analgesia. So again, they are good in some situations. It's case by case. We look at what are we trying to achieve, because sometimes instead of prescribing tramadol together with paracetamol, you give your patient Tramaset. It has lower doses of tramadol, lower doses of paracetamol, and they're able to get the benefits of both classes of medicine.
Yes. Now, thank you so much for those responses. I hope you are able to hear me. Sorry, my internet is a bit.
Yes, Dr. I can hear you.
Thank you. We'll now allow us to stop there for the Q&A. I think we've answered most of the questions, and also we'll have the presentations to be able to share. We'll go into a short session where we'll have Felisa Mwangangi just giving us a short presentation on what they do at Menarini. Welcome, Felisas.
Good afternoon, everyone. Kindly facilitate me to share my slides.
Nelson, you can stop sharing for Felisa to share.
Felistas, just go to share your screen. We are not sharing anything, it's from research. You'll be able to stop and share yours.
I believe my slides are visible. I will rush through the slides. My name, as mentioned, is Felisa Mwangangi from Menarini, Kenya. Menarini is an international company, and despite the serious side effects highlighted with NSAIDs, we have an NSAID in the market that we are marketing. But compared to the other NSAIDs, our NSAID, KNH, which is the ketoprofen trometamol, is a pure enantiomer, and being a pure enantiomer, the side effect profile have been taken care of to a greater extent, and therefore it makes the product much more better tolerated, as you'll be able to see. I will rush through the slides, although there are a number of them. KNH is able to break pain within 15 minutes, with an onset of action being 8 minutes, the first 8 minutes. As you can be able to see here, I'll only highlight the pain burden globally. It's about 77 million people in the world complain about pain, with 9 out of 10 having a regular pain every day. And as you can be able to see, pain is a major problem in the world, both chronic and acute pain, which needs to be taken care of, because unless it's taken care of well, then we end up having chronic complications, and they become more difficult even to manage. Now, if we don't take care of especially the acute pain, and it becomes chronic pain, then the patient becomes more exposed to those complications that have been being discussed, because now the pain management will have to take a different route altogether. The latest ladder from WHO for pain treatment, this is what was released 2 years ago. And as you can be able to see, they highly recommend the use of non-opioids analgesics, and this includes NSAIDs as the step one of pain management, especially in acute, chronic, without acute crisis of chronic pain. Of course, the rule of the thumb is to use the shortest pain, the shortest treatment for the shortest period of time. And that's the reason why majorly pain relief with the NSAIDs is recommended for within 3 to a maximum of 5 days. Pain management, in pain management, we usually say that an ideal painkiller for acute pain should provide a rapid onset of action and reduction of the side effects. In this picture, the NSAIDs are effective analgesic and pyretic and inflammatory drugs, and they are benefiting very many millions of people every day. I picked this chart, which was done by Goodman and Gilman in the pharmacological basics of the therapeutics. And a good painkiller, as we all know, should have a very good analgesic and a pyretic and an inflammatory benefit. Quite a number of questions have come about diclofenac, whether it was removed from essential drug list. I believe in this year, the month of June, we actually saw an policy advisory document from Pharmacy and Poisons Board Kenya. And this comes as a follow-up to the one that had been released in 2017 by WHO, whereby, yes, they flagged diclofenac as because of its overuse and the exposure it has in terms of cardio-related problems. However, in terms of the relief of pain, they recommended, or rather they have indicated in their own communications, they kind of gave a higher indication of the use of propionic acid derivatives, whereby we have ibuprofen, as well as ketoprofen and dexketoprofen. And this is because these particular molecules mimic the aspirin in terms of relief in the 3 chemical characteristics as analgesic and inflammatory and antipiretic molecules. However, they have the benefit of a better safety profile compared to what we face with the majority of the other products. Of course, paracetamol happens to be also one of the gold standards of pain management. The only challenge we have with paracetamol is it has a zero activity in terms of anti-inflammatory benefit. That is why when it comes to propionic acid derivatives, they come in handy in the sense that they have the 3 properties that you are looking for in terms of management of pain, fever, and inflammation. Now, KTS, which is dexketoprofen trometamol, has the oral formulation of 25 milligrams, which is a film-coated tablet, and it has a greater advantage, well indicated for symptomatic treatment of pain of mild to moderate intensity. When it comes to musculoskeletal pain, dysmenorrhea, which was earlier inquired, if you're looking for an alternative to diclofenac, KTS will actually be a better molecule to use because it's a pure enantiomer. And what we mean by this, all the chiral molecules, as you know that NSAIDs are chiral molecules, have both the levo and the dextro isomers. What Menarini did, they removed the levo isomer that does not have therapeutic benefit, and they replaced it with the trometamine salt to stabilize the molecule. And therefore, we have kind of like half of the dose, giving double the efficacy. Now, KTS tablet, the 25 milligram, it's indicated for mild to moderate pain, and the dosage is 1 tablet twice or 3 times a day with a maximum of 75 milligrams. As I've mentioned, it's 25 milligram tablet, a maximum of 75 in a day, depending on the pain intensity. So you can actually give it either twice or you can give it 3 times, depending on how severe the pain is. And most of the chiral NSAIDs I've mentioned have effects. However, the effectiveness of KTS is attributed to the enantiomer that has, or rather, the benefit attributed to the S enantiomer. The R enantiomer has been considered as useless and potentially harmful ingredient. So the S enantiomer of ketoprofen may be administered as half of the dose of the racemic compound with the same analgesic effect. This minimizes additional toxicity and the interactions mediated by the less active enantiomer, and a pure enantiomer may be administered as half of the dose as I've mentioned. Now, the possible benefits is a fast onset of action of analgesic, of the analgesic benefit compared with the free acid form, and lower potential for gastric ulceration. So KTS will give you faster onset of action, very good efficacy, and lower exposure to the side effects. There is a study that has compared KTS with ibuprofen. We've seen that both of them are propionic acid derivatives, and as you can be able to see, the efficacy benefit of KTS was higher because for the area of moderate pain, mild to moderate, you notice that the intensity, the pain intensity at the 6th hour and 8th hour after taking the analgesic, there was significance. As you can be able to see on this, no pain down here, moderate pain, mild pain, moderate, and intense pain. For KTS, you notice that the no pain and moderate mild pain is much more bigger in terms of the scale, taking 70% as compared to what you'll be able to see. And this gives us a greater benefit. You'll also notice that in this particular kind of study, the evaluation was done with 25 milligrams of KTS, dexkitoprofen trometamol, compared to the standard dose of 600 milligrams of ibuprofen. The pain relief scores with KTS as compared to ibuprofen for your patient who is in pain. KTS was also able to show better efficacy, better pain control in compared to an ordinary ketoprofen, as well as 500 milligrams 6 hourly, with KTS being 8 hourly. And therefore you have better pain intensity management with KTS compared to the other two. It's indicated for lower back pain, where the study was done, as compared to now, even the tramadol that we have been discussing about, you can see that with KTS, by the end of the time, you have better pain control. In dental pain, KTS was able to give better pain relief. Compared to the baseline of pain, we had more than 50% of pain relief with KTS as compared to ibuprofen. Also, the study shows that in osteoarthritic pain, KTS was actually more effective, was able to reduce the pain much more better with the 3 times dosing compared to diclofenac. So you have a better alternative in terms of pain relief with dexkitoprofen or KTS compared to diclofenac. We also have KTS available as 50 milligrams per 2 ml injection for infusion, and it is used KTS solution for injection or concentrate for solution for infusion can be administered either intramuscularly or intravenous. For intramuscular, because it's a 2 ml ampule, KTS solution should be administered as a slow injection deep into the muscle, so that we can avoid pain at the site of injection. For intravenous use, the diluted solution should be administered as a slow intravenous infusion lasting 10 to 30 minutes. While the intravenous bolus, if necessary, the content of ampule of 2 ml of KTS solution can be administered as a slow infusion, slow intravenous bolus over not less than 15 seconds, sorry. This helps in reducing the pain because, as you have seen, it's a 2 ml. Pushing it quickly will have the patient experiencing pain as the drug is going through the vein. And of course, KTS is recommended for post-operative pain management the onset of analgesia for dexkitoprofen was significantly faster than diclofenac by a mean of approximately 18 minutes. So it will be able to take care of the pain faster and even longer, even than the diclofenac that is commonly used for pain management. The duration of analgesia for dexkitoprofen was also significant for over 50 minutes when the two were compared in this particular study. Now, if compared with tramadol, the pain score and morphine requirements similar in both active groups. You find that patients who were on KTES required less rescue dosages. And that is why KTES is actually recommended for balanced analgesia in terms of management of pain for patients who have undergone post-operative pain or rather surgeries, and they require a pain relief. Now, this shows us the intervals of use of dexkitoprofen in reduction in pain in morphine requirement, and it reduces the requirement of an opioid by 1/3. And this study incorporated 172 patients, whereby KTES was compared with other molecules, and therefore dexkitoprofen, which is KTES, happens to become a better molecule when we are requiring a combination of post-operatively. I'll skip these two. In terms of versatility of the use, KTES can actually be directly mixed or diluted, as you can be able to see. And this enables us to, or rather the nurse or the doctors to have easier use of KTES with the patients in the hospital, because you do not need to use it alone. You can actually use it either in combination or use it diluted directly or indirectly. Now, we have highlighted a lot during this study, and this is where I wanted to spend some bit of time to be able to show how KTES, to be able to show the benefit of KTES in terms of its safety profile. There was this study in this particular analysis of 92,163 patients in 5 European countries in over 17 hospitals. There was an elaborate study that was undertaken to be able to assess the cardiovascular tolerability of the various NSAIDs and the estimated and to estimate the risk of hospitalization later after the products, the patients had been put on 19, actually 23 NSAIDs. As you can be able to see, all these NSAIDs were included in the study. You can be able to see the odds ratio. On this side, it shows the level of exposure of the patients after use of the various NSAIDs. So this becomes the high risk, and this is where the particular product show the benefit or the safety margin of the product. As you can be able to see, for the number of patients who were used, the odds ratio are here. From ketorolac all the way to oxaprozin, and oxaprozin is currently not in our market. Out of these molecules, and this paper is actually available, it's a BMJ paper, which is free access. You can actually be able to access it online. You'll actually be able to see that out of most of these products, only 3 products showed a greater benefit or a greater safety profile in terms of the risk level. And among the 3, dexkitoprofen showed a greater benefit. The only other product that is available in our market is celecoxib, which was also showing a benefit on the left side, on the odds ratio. And therefore, not all NSAIDs are as terrible as it's painted. This study was done after the initial study that had been undertaken to check the exposure or the high risk of diclofenac, because it brought in a lot of outcry globally why diclofenac was picked alone to be studied and to be checked on its exposure. So now there was a need for all NSAIDs to be studied and to see how exposed are they in terms of cardiovascular safety. And this clearly indicated that quite a number of the other NSAIDs are equally as carry a higher burden in terms of exposure to the patients. However, there are some that are still better tolerated and they do not expose the patients to cardiovascular. I believe nephrotoxicity that we have discussed a lot at length here is part of the cardiovascular, forms part of the cardiovascular disease. And therefore, when you are recommending or you are prescribing your product, an NSAID, you can actually consider the ones that do not expose your patient more. And because we all believe, from what the discussion was, that NSAIDs still are relevant and they are required, we need to use them for a shorter period of time and the lowest possible effective dose is the rule of the thumb. KNH 25 milligram has a very good tolerability, and this was a safety profile that was undertaken for 7,000 patients. And as you can see, the results clearly indicate that dexkitoprofen, in terms of GI irritation, or at least one, the first column here shows at least one adverse event, while the second one shows a GI disorder. And out of all this, KNH scored far much better as compared to our ordinary NSAIDs that we are using every single day, and our patients are able to access either through prescription or through over-the-counter medication. KNH gives better tolerability, both in terms of GI irritation as well as overall adverse events. As I sum up, this is how the two products look. We have KNH 50 milligram per 2 ml, and we have KNH 25 milligram. Pardon? Actually, this is my last slide. And we also have our Fastam for topical pain management. So we have both KNH as oral, KNH as IVIM injection, and Fastam as our topical drug for pain management. Thank you.
Thanks, Felisa, for that presentation on KNH. And thanks for the sponsorship for the webinar. And we really appreciate your presentation. We'll now just have, we are now coming to an end and we're actually out of time. So I'll just allow the final comments from Dr. Nafula and Dr. Bombegi, and we call it, Dr. Nafula? No, she's actually there. Dr. Bombegi, any last comments?
Thank you very much for all the presentations, to all the presenters. NSAIDs are indeed a very important group of medications. And we have seen the benefits of KNH and the Fastam and all the important information about the drug. I think it's going forward, we all use NSAIDs at one point. It's just that we should all take caution, especially if your patient has kidney disease. Thank you.
Thank you very much. So thank you, everyone. We'll have another session in the coming week on Wednesday, and we'll be able maybe to answer some of those questions that we're not able to answer today. You are welcome for our session tomorrow on nursing series, KNH Code of Conduct and Ethics, and then for our coming sessions next week. For the CPD points, you'll be able to get them. I think for the medical officers, it has been quite straightforward in our emails. For the nursing series, we get them within 48 hours. For the clinical officers, we usually have the registers sent to the council itself. And for the pharmaceutical, for the pharmacies and pharmaceutical as the farm techs, we have them on the portal. You have to pre-register on the portal. For further information, you can email us at knhcpd@gmail.com. Thank you, everyone. Have a lovely evening. I'm Dr. Karingo Agnes, KNH Medical Research. Thank you.